Our next panel is Clearing the Path to Better Health, Overcoming Barriers. AA and NHPI communities face distinct health challenges, and that includes barriers to care and disparities in health outcomes. This panel will explore the factors influencing these challenges and discuss strategies for improving healthcare access and outcomes, and that's through policy and community-driven solutions. Our moderator for this panel is Joyce Liu. She is principal for the Venn Group, which works with clients on government affairs and strategic communications. Joyce has successfully led the lobbying and communications efforts for her clients on over a dozen bills and campaigns, including federal nominations, veterans issues, immigration, and the passage of the Chinese-American World War II Veteran Congressional Gold Medal Act. Please welcome Joyce and the panelists to the summit.
Well, thank you everyone for being here today. Thank you, APAICS, for having us for this very important discussion. As we know, there's a lot going on this week, and we really appreciate you all for making your way out here. So I wanted to introduce our esteemed panel. I'll start on my left with Councilwoman Nina Ahmad from the Philadelphia City Council, and then Adam Carbolito, Director of Policy and Advocacy from the Association of Asian Pacific Community Health Organizations, known as APCHO. Selena Goreg, CEO of Women Heart, and then Paolo Pontemayor, Senior Director of Government Relations from the Catholic Health Association. So thank you all for being here today to talk about the distinct health challenges for the Asian American, Native Hawaiian, and Pacific Islander community, and the barriers to care and disparities in health outcomes. So just quickly kicking us off for each panelist, starting with you, Councilwoman. What is the most pressing health disparity that our community faces, and the work that you and your organizations do to identify and to address these disparities?
Well, thank you so much. It is wonderful to be here and see so many familiar faces. And I must congratulate Madeline for this amazing event and how much this organization has grown. When I shared this with my colleagues when I'm missing council session today, they said, oh, wow, that's amazing. They were very happy for me to be here. I think one of the fundamental pressing issues is the lack of disaggregation of data. We are sort of a 50 different country large community under this umbrella term, AA and HPI, right? And our needs are so different. We're the only racial group in our census that does not share a language, does not share how we look, and there's very little tying us except for our cultural norms. And I'll just say this, before I came here, we were in the little area mingling, and I met a few people, and one of the things I was telling them, the one thing in an AA and HPI community event you'll find is food. So I spend a lot of time in city council. We don't have big budgets, so I go to all these sponsors. Anytime we're doing something, food is the first priority for me. I cannot do something without food. So going back to the disaggregation issue. So in Philadelphia itself, for example, we have diverse groups from the API community. We're about 8% of the population. And the Hmong population, the Cambodian population have very different needs than the Chinese population or the Indian, South Asian versus Bangladesh, where I'm from. I come from a community that is not well-resourced. So the needs, the blood pressure needs, the cholesterol needs are different than what you would see in a similar background of South Asia, meaning Indian population. So I think disaggregating the data is critical. When I served on President Obama's API Commission, that was one of our driving jobs to look at disaggregating data. So I'll stop here, but there's a whole lot more to say.
Thank you, Joyce, and I also just want to appreciate APAICS and the APAICS team for putting on such an outstanding event and bringing together so many individuals from across the country to come together and talk about some of the pressing challenges affecting our communities, especially at a time when many of our communities do feel under strain right now. And this is a difficult question for me to answer because there are so many disparities and challenges that our communities face. For those who aren't familiar, I'm with the Association of Asian Pacific Community Health Organizations, or APCHO for short. We're a national nonprofit that represents community health centers and other community-based provider organizations that works to improve health status and outcomes for underserved Asian Americans, Native Hawaiians, and Pacific Islanders in the United States, the U.S. territories, and the freely associated states. And our members, our federally qualified health centers, provide care to nearly 750,000 patients annually, usually low-income patients who are marginalized and don't have consistent access to health care. So when us at APCHO think about the disparities facing our communities, it's really in two buckets that we do. First, it is on the structural barriers that our communities face. Insurance status is the #1 factor in an individual's ability or decision to seek care. And there have been a lot of progress that has been made since the Affordable Care Act, the extension of tax credits that made buying insurance on the marketplace more affordable for individuals, and that led to a significant decline in uninsurance rates for our communities. But there's still a lot of work to be done, particularly when we get into the various subgroups within our communities. And Medicaid has been a huge improvement and ability for our communities to get care primarily for low-income individuals. About 25% of Asian Americans in this country, 1/3 of Pacific Islanders and Native Hawaiians in this country rely on Medicaid for their health insurance. And it is important that we continue to sustain these programs, both Medicaid and the tax credits that make health insurance affordable, because we know that this is how our communities receive care. Second, and I know I'll talk about this a little bit later in the panel, but immigration status. Half of our communities are foreign-born, and depending on how long you have lived here, what type of immigration status you have, that is also a barrier for an individual to improve their health outcomes. And as the councilwoman was saying, getting granular data on our community to help us understand how is it that we're going to provide those targeted interventions and really understand how is it that we can reach out to the various subgroups within our communities. And then the second aspect on how we think about disparities in our communities at APCHO is on some of the systemic barriers. Language access is a huge challenge, and individuals getting the care that they need. Access to culturally competent healthcare providers, individuals who look like us, speak our language, and are able to provide care in a cultural context. And lastly, there are a host of disease disparities that affect our communities. I can get into many of the statistics. I know that there are various breakout panels that talked about some of this, but it is like, how are we providing, again, those targeted interventions to our communities to address those disparities, and how is it that we're providing better care in ways that are culturally, linguistically appropriate to our communities?
Thank you, Adam. Selena?
Thanks so much, and thank you again to APAICS for inviting Women Heart to be here today. What has already been said applies very much to women's heart health in the Asian Pacific Islander community, but what I want to focus on is the intersection between gender and culture. Mm-hmm. I think one of the things that we deal with at Women Heart on a regular basis is the idea that women put themselves last. And I think that is just as true in the Asian American culture as it is in lots of others. And that is relevant to women's heart health. Heart disease is still the #1 killer of women, even though the perception out there, and in fact the awareness out there, is that it's breast cancer. Now, we don't like to compete with our breast cancer sisters, but heart disease does not get the attention and the awareness that it deserves. So when we think about it in the context of the cultures, the multitudes of cultures that exist in our community, one thought that I come back to time and time again is, how are we celebrating the role of women. And so in so many cultures, including my own, I'm Filipino American, we celebrate women's suffering, right? We create martyrs of our women. We say, look at her, she puts everyone first. She puts herself last. Like as if that is something to celebrate, right? So for us, it's really about thinking sort of systemically and culturally about how we celebrate self-care, especially amongst the women in our communities. The other thing I want to touch on is food, right? Diet is a big part, obviously, of our ability to control our heart health. And even though disaggregation in cardiovascular research is, again, very, very minimal, what we do know is Filipino Americans have twice the rate of heart disease as their Caucasian counterparts. But if we look at the spectrum of countries and communities in the Asian region, the Japanese culture have the lowest levels of heart disease because let's say the traditional diet is much similar to the Mediterranean diet, which we've all heard to be quite heart healthy. So I know we're going to get into lots of other ways to think about disparity, but I really spend a lot of my days thinking about how culture impacts the way we think about women's heart health and also how we live heart health every day.
Great. That was a tough act to follow with these esteemed speakers. I'm so glad to be part of this panel and also to be affiliated with the Asian Pacific American Institute for Congressional Studies. So I'll take 30 seconds to do a quick shout out to this organization. I was an intern and a congressional fellow for this program, so they keep finding ways to bring alumni back. So I'm really glad to be up here. In my day job, I am the Senior Director of Government Relations for the Catholic Health Association. It is the largest provider of not-for-profit care in this country. Our 2,200 member hospitals, long-term care facilities, clinics, and other healthcare organizations serve people all across the spectrum, including the Asian American, Native Hawaiian, and Pacific Islander population. 1 in 7 patients every day is cared for in a Catholic facility. And so to be able to be affiliated not only with APAICS, but with the Catholic Health Association and to talk about this issue is truly an honor. I think that, as Adam had mentioned, healthcare access is probably the number one issue that many in the AA and NHPI community are going to be facing. Right now, there are discussions in the House of Representatives to really look at ways to transform Medicaid, change components of the healthcare tax credit as part of the Affordable Care Act. So those hearings and markups are going to be happening later this afternoon. So it's a pretty busy day for all of us. I'll take it to another place in terms of what is the actual largest health issue facing this community right now. And I will say that these are the things that you don't hear in the headlines. While we have been around in Washington, D.C. this year, it's a new normal. There have been real big concerted efforts to actually dismantle the offices of minority health in the Department of Health and Human Services, which for many in our community, that is our first door that we enter to actually look for how we can actually serve the A and NHPI community. Second, there are really new ways that universities, institutes, not-for-profit organizations, and researchers are being challenged right now. NIH grant funding, especially as it relates to, quote-unquote, disadvantaged populations and people who, depending on where you are on the viewpoints around DEI, are actually being engulfed in kind of a lot of that rhetoric right now. We all know that research for A and NHPI populations is really in the single digits, despite us making close to 6% of the US population. We all know, as we have heard, disparities depending on ethnic group and really where people come, depending on immigration status, are truly the things that confound kind of how we can get that true picture of what our true health disparity is. In the last 15 years since the enactment of the Affordable Care Act, we've really made a lot of progress, really chipping away at the low uninsurance rate for certain groups of Asian Americans, yet we still know that there are lingering effects, especially for small business owners who are Asian American, Native Hawaiian, and Pacific Islander, who have no place to actually pursue affordable health insurance options. And so not only do we have issues related to how we can find the research to build the evidence base to really make a case for why it's important to really advance Asian American, Native Hawaiian, and Pacific Islander health, we also are now at that place where we are also maybe limiting the ability for individual members of the AA and NHPI community to actually take control of their health outcomes through challenging kind of where they get health insurance. And we all know the stories. Access to health insurance allows for better health outcomes in a community. Connection to a primary care provider allows you to really control chronic diseases, which are some of the most prevalent in some AA and NHPI communities, diabetes, issues related to kidney disease. I grew up in a family where it is kind of normal to essentially say, it's now your turn to actually get gout, without realizing that there are some cultural components in there that we really need to address. And another point of personal privilege, Adam and I are both from Guam, so we always have to make a different shout out, or a concerted shout out to our fellow Americans residing in the US territories who really are probably facing some of the largest health disparities in our country when we think at the AA and NHPI community level. Thanks.
Thank you all. And now we're going to take a bit of a deep dive into some of the items you've mentioned. So, Councilwoman, hopefully Congresswoman at some point.
From your mouth to God's ears.
Personal privilege for that one. Councilwoman, what is a health issue impacting the Asian American and Native Hawaiian Pacific Islander community that might be currently overlooked?
So I'm actually working on a bill right now. I want to introduce my legislative director, Julian Sham. He's here, so who will remind me if I say something wrong. So we're trying to pass, we are going to pass, not trying to pass a bill to make sure that vaping products are not sold to people, children under 21, right? That's the law. That's the federal law. That's the state law. And that's how Philadelphia operates. However, there's a concerted effort by the tobacco industry to target young people. We are not able to do anything about the flavorings and all of that. Previous to me being on council, somebody tried to pass that bill and that was overturned. So there are all kinds of legal implications, but the issue is that it is very, it is a problem, particularly in underserved communities. And not just in Philadelphia, which doesn't have a very large Native Hawaiian population, but across the country, particularly in Hawaii, vaping is a real problem in our young people in the Native Hawaiian community. And so we need to talk more about it, we need to highlight it more, and we need to tell people why, the sort of the basis for why you get popcorn lung when you inhale these additives in the nicotine-based vaping products. One of the big things, in addition to vaping, is looking at the increase in breast cancer in AAPI and NHPI women. That has been a recent phenomena. We still are yet to quite figure out what, but it seems that they're leaning towards stress and lifestyle changes, particularly in diet, that people are, changing once they're here in this country. But it's true not just of first generation or immigrants, it's true of all categories, particularly young women. That is really very alarming that the breast cancer rate is so high. And again, it is not a much discussed issue. And I know everybody will talk about many issues. Another big issue is mental health care, is making sure people first get over the stigma of receiving mental health care, and two is understanding suicide rate is very high. I believe young AAPI women, young women, are the highest segment of our population to have suicidal ideation. So we need to, these are things we don't talk about, right, in our communities. And that, another thing I can say for all the 50 groups, I think this is an issue people do not like to talk about, because this is, and this is true of the African American community as well. I talk cross-community about this issue, and taking mental health care is seems to be an admission of failure of the and lack of strength. And we have to really reform that thinking by making sure we publicly talk about it. And this is why spaces that I occupy, it is my responsibility and duty to talk about it and talk about, what a change it can make, right? I have 2 young daughters, and I use them as my examples of saying, as an immigrant to this country, I came from a war-torn nation. I experienced trauma. And so when my children were whinging and whining about some things in their life, to me it was like, what are you talking about? Like, I just lived through a war, and that was just wrong on my part. Their life experience had no war in it. Their only war they knew was from what they heard from their mother and father, and what war was happening because of gun violence in our country. Separate but related issue. That's another issue that's a real problem. So I had to, both my husband and I, who also lived through the war, had to step back. And I want and say that they have a different reality than I do. They have to live in 2 worlds. They have to live in a world that we make at home, and we have different kind of norms, and then they have to go work in school or work or wherever they go, and they have to adapt to a different environment with different values. And that puts a real schism in your mental health. You have to really know how to code switch in a real way. And I know other communities also face this, so that's why the conversation needs to be broader, so it's not just this community. And that's what I would really underscore for all of us to encourage. And it doesn't mean that we maintain our victimhood forever. Let me be clear how we need to embrace mental health care. So this is a lot of the immigrants like me look at it as, this is just you whining and wanting to make your whining relevant by saying it's something. That's just wrong. I'm wrong when I ever thought of that. So I just want to make sure people understand the importance of mental health care, because it impinges on everything else we do. Our rest of our health care is intersecting with those needs. So I'll stop because there's so much to talk about. I didn't talk about gun violence. That's a massive problem.
I think we might need a few more panels for all of these issues.
Yeah.
So thank you. Adam, I know you mentioned this briefly earlier. The majority of our A and HPI community are foreign-born. So how do immigration-related barriers impact healthcare access and quality?
Yeah, I think there are several layers to this question. First, there are structural layers where immigrant communities face specific statutory restrictions on the ability to get care. When an individual who immigrates to the United States, when they try to receive public benefits, Medicaid, for example, they're unable to do so within the first 5 years that they reside in the U.S., and that poses a significant challenge because at the moment of in a period of time where an individual is most vulnerable, getting to know a new culture, a new place, a new land, them being unable to enroll in some of these healthcare programs does pose a significant challenge with the 5-year bar. Second, there are different categories of immigration status that, depending on which one you reside in, you may be either completely ineligible for any of these programs, or again, there are barriers for you to get those programs. Second, and I think it's something that hits a little bit more close to home for many of our communities, is that especially over the last several years, there has been a deliberate attack on immigrant communities and fear-mongering against our families, against our friends, and against the broader communities in which we live. The efforts that the current administration is taking to detain individuals, to deport individuals, and to create fear is really having downwind effects on the ability of individuals who are here, whether your families are here legally or you may be undocumented, it is having an impact on an individual's decision to go seek care, the care that they need. We've seen a decline in patients wanting to go into our community health centers because of fear that either utilizing the health benefits that they are eligible is having, or because they think that ICE is going to come and raid some of those clinics. We've seen ICE and other law enforcement agencies position law enforcement assets outside of our community health centers as a scare tactic. And there's been instances where not at our health centers, but at other sensitive locations where ICE has actually gone in and conducted raids in those communities. And I think a second aspect, and it's something that Paulo touched on, is right now in the House of Representatives, Congress is negotiating and considering legislation that would further restrict immigrants' access to receive health care and other benefits in which they're eligible. There are proposals that would make it so that undocumented individuals cannot receive any type of health care within the country, even if it is not federally paid for, and it would penalize states if they do that, if they provide care to undocumented individuals using their own state funding based off of policy decisions made in state capitals and city councils, and that'll have a detrimental effect on our communities. There's also further restrictions on requiring either citizenship status verification in order to enroll in programs, or making it so that individuals must have a social security number in order to enroll them or their families in benefit programs. And that'll all have trickle-down effects, not just to an immigrant, but to their U.S. citizen children, to their other family members. And this is all a deliberate attempt to try to other immigrant communities in this country, and it is having both the mental health impacts on our communities. It causes deep trauma, not just for immigrants, but for the broader communities, for the healthcare providers that serve them. We've heard from our community health center members that it's not just patients that are being adversely affected by this, but it is also having a detrimental effect on the providers who serve them as well, because they are the ones on the front line having these direct interactions with patients. So I think that immigration status has, long been weaponized against communities, and it is continuing to be exacerbated and providing more fear in our communities that is making it more difficult for us to get the care that we need, the care that we deserve, and quite frankly, the care that we're legally entitled to.
Thank you, Adam. And I think all the panelists pointed about this before, that our community is not a monolith. We come from 50 distinct ethnic groups, and we speak over 100 different languages. There's quite a few unique needs in both access and care. Selena, can you speak a bit on the disparities within our community and on women's health and how we can provide support?
Yeah, thanks. To go back to what the councilwoman said in the beginning, the disaggregation of data, right, in research is woefully minimal. Mm-hmm. And so I wish I could say more about, right, the disparities across the different communities. But what I think in this moment, what I really want to emphasize is that we actually really need to band together around women's health more broadly, mm-hmm. because there's an existential threat around women's health right now, right? Yep. If you're writing a grant about women's health research, you can't even use the word woman. I mean, let that sink in, right? So I think that this is a really important question about the future of women's health writ large. Yeah. And we all sort of need to come around and come together. I will also just point out that the disparities that we see in women's heart health are true across the board. So women are twice as likely to die from a heart attack when compared to men after they've already had a heart attack, right? So that's talking about the healthcare system, right? If you survive a heart attack, you're a man and you're a woman, a year out, the woman is twice as likely to die. So that, there's some systemic, back to Adam's point, there's some systemic issues that we have to address from a gendered perspective. The other thing that's really frightening, keeps me up at night, is that women are much more likely to be dismissed when they go to the ER with chest pain and sent home and told it's just anxiety. Research has been done to show that 90% of those people that show up to the ER with a chest pain and then are sent home without a diagnosis actually end up having a heart issue. Yeah. 90%. So essentially, all of them are not believed. So that is the work that Women Heart is trying to do, is really trying to sort of tease out how we can empower women when they show up to the clinical setting, right, to fight some of these sort of systemic injustices that have to do with simply being a woman. And I think that's a rallying cry for all of us, right, thinking this through. I mean, like I said, it's existential when, right now our government is actively trying to, right, like deny us the ability to have answers to these questions that are life or death.
Thank you so much. And Paolo, how can healthcare systems and providers build trust and better engage with their communities? And how can we build upon existing legislation to improve access to care for our communities? I know this is a double whammy for you.
I know. Let's see if I can remix that to a good answer. So yes, healthcare providers, healthcare systems play a huge role in the delivery of care in this country. I think more can be done. I think that the bare minimum of having language access services, culturally competent care, and really treating patients who come into any healthcare facility with dignity and respect is kind of the bare minimum. Thankfully, there have been recent moves across the country to really get to the core of this. I think for the longest time, public health has been very focused on what we know as the social determinants of health. And I think the healthcare community and healthcare provider community is now catching up, knowing that not only is it an investment in communities that would look more like the patients that they serve, whether it is through a healthcare workforce pipeline, the future nurses, future doctors, physician assistants, therapists, social workers, and allied healthcare that can reflect a community that a healthcare provider is serving is an important piece. There's movement towards really understanding, and I think that there are several states that have been much better, just being able to get kind of the research dollars in place to really show that the delivery of healthcare in a culturally competent way achieves results. I think that there are metrics in place through the Centers for Medicare and Medicaid Services around culturally competent care, really pushing forward kind of the things that we know as a community have been asking for many years that we can do. Lastly, and I think that this goes, again, beyond my pay grade, but I really have to put it out there, is healthcare system leadership and diversifying that pipeline up there where people make the decisions around healthcare systems and the decisions around allocation of resources should accurately reflect where and how our communities engage with the healthcare system. We all know that there are some communities, as Adam mentioned, that seek care in emergency rooms without any fault of their own because they don't qualify for any health insurance product. Mm-hmm. And we also know that in our community we have some of the highest educated, highly trained individuals who are actually administering the healthcare. And so how do you bridge kind of that huge divide and kind of really starting to unpack the monolith community that we are so that we can all row in the same direction together to achieve better health outcomes as a community as a whole?
Thank you. And then quick lightning round to close us all out. What's one key takeaway you'd like to leave the audience with today, starting with you, Councilwoman?
So I want to just highlight work being done to understand the impact of trauma, generational trauma, on our health outcomes, right? And I'm speaking about the work of Dr. Mobeen Syed, who is looking at things like the history of famines. And I come from Bangladesh, which was part of India. We were colonized by the British, who made sure our food resources were sent elsewhere, and we went through famine year after year after year. And he is making that connection, as many others have, is the modulation of our gene expression is impacted by that history of encountering famine. meaning South Asians have a very high rate of diabetes, very high rate of heart disease from cholesterol, and for having that kind of experience and coming down through gene expression, not changing the actual DNA. I'm a molecular geneticist by training, so bear with me. Not changing the actual DNA structure, but changing how the gene is expressed, the proteins are expressed, has an impact. So when we have healthcare for people who come from that generational experience, we should have different kinds of health measures for them. The BMI is being looked at differently, making sure they can't exercise the same level as someone else. Their food groups need to be different. So again, disaggregating the actual care to this lived history that we bring, which is present in us. And a lot of our communities have experienced a lot of trauma. And understanding that that has an impact, even though we might be few generations removed from it, is critical. So I just wanted to highlight that. That's my new thing. I want to really get into that much more.
Thank you. Adam?
Well, we're in DC, and I think one thing that I hope everyone takes away is that what we've been talking about up here is our lived experience, right? It is something that we know at an intimate level, and I think many of you all in the audience could actually take my place up here and talk about this as it pertains to yourself, your families, your communities. And I think what's important is that we take those stories, those lived experiences, and really communicate that to the individuals who are responsible for making policy making, not just at a national level, but in your states, in your cities, in your counties, and especially at this time, where a lot of the work that is going to help improve healthcare in this country is going to be decided at state and local levels, aside from what Congress is currently debating. So I really do encourage, contact your elected officials, explain to them why, when we're talking about healthcare, this is a personal issue. This is something that affects your families, yourself, your communities, and why is it that they need to work to protect the public health infrastructure that we have, to build the pipelines, as Paula was saying, so that our communities are actively reflected in the healthcare system, and to enact good public policies that will not restrict our access to healthcare, but really expand on some of the successes that we've made over the last several years.
Thank you. Selena?
I'm going to stay at the personal level. So even though women live longer, they spend 25% of their lives more sick and unwell. So this is the takeaway I hope all of you, maybe in particular the men, take from today. Make sure you're celebrating self-care in the women in your lives. Uplift them. Make sure you're giving them a break every now and then. Right? And listen to yourself when you say, isn't she amazing? She sacrifices herself for everybody else. Let's change that narrative.
Thank you. Paolo?
That's great advice after a wonderful Mother's Day. And so, yes, please uplift the women in your life who really make a lot of our work possible, and really being able to be here up as advocates. And so my takeaway, very similar to Adam, is be your own healthcare advocate, not only for yourself, but for your communities. And also, if you see a need that needs to be changed, take an example from the Catholic Sisters, who helped found some of these large hospitals that have now proliferated all across the country. And they went to places that they saw a need and needed to change something. And the last thing I will say, we didn't get a chance to talk about it up here, is we all need to start thinking about how we will age in this society. Mm-hmm. Aging issues in this country are severely underlooked or overlooked. We all believe that there is going to be a system in place out there when we grow older, our parents grow older, our grandparents grow older. So please think about what healthy aging will look like in the next couple of years.
Thank you all. Please give a round of applause for our esteemed panelists. And thank you all for coming out today.